So patients with CLL treated with BTK inhibitors can have cardiac toxicity, and that's been seen really in the entire class of drugs, most especially with Ibrutinib when compared with the second generation acalabrutinib and zanubrutinib, but accumulating data suggests that cardiac toxicity is seen with all of these agents. I think one thing that's very difficult in the CLL patient population specifically is that it tends to be an older patient population. People have other comorbidities, so it can be challenging to tease out the direct effects from a drug versus something that would have happened to the patient, whether they were taking a specific CLL therapy or not. As well, I think another challenge is understanding, for this particular patient, do the risks and benefits of potential cardiac toxicity, do the risks of that outweigh the potential benefits of a very effective drug in the disease? I think that unfortunately is always going to be difficult, and it's just an individualized decision for each patient. Additionally, if a patient develops cardiotoxicity on a BTK inhibitor, you could potentially switch to an alternative BTK inhibitor, but in some situations, that is still the best treatment option for the patient. And so it's challenging to try to figure out for an individual patient, again, where the risk-benefit ratio lies when you do observe cardiac toxicity. I think as we gain additional information, not only about incidence and specific risks for cardiac toxicity, but really what we can do to manage cardiac toxicity when it occurs, we're going to be in a better position to really make these decisions in the future.